Good morning, all. Today I am discussing two cases with their because of their rare presentations. So, in the first case, there, as we know that there are three basic types of congenital diaphragmatic hernias: posterolateral, Bogdelic, anterior Morgagni, and the hiatal hernia. Our first child is a 5-year male presented with frequent non-bilious vomiting immediately after feeds since birth. This is associated with lower respiratory tract infection since birth and failure to thrive. At the time of presentation, patient has tachycardia, tachypnea, SpO2 is 92% at room air with the malnutrition. On examination, there are no features of Down syndromes or other any anomalies. Echocardiogram was within normal limits and chest X-ray shows opacity in the lower lung field right side with the air shadow at the right side lower lung hemithorax. Upper GI contrast study with water soluble contrast shows gastric contrast in the right hemithorax, kinking of gastroesophageal junctions, grade 5 GERD, and we are suspecting torsion in this case because the stomach is a little bit horizontally lying. We manage the case on conservatively on prokinetics, frequent small rise to feeds, aggressive chest physiotherapy on which the child slowly responded, and URI is under control. CT scan shows a 2 into 2 centimeter defect in the substernal diaphragm with stomach, small bowel loops, and colon in the right hemithorax. Plain film CT also shows in axial view show that there is shadow, air shadow is at the level of cardiac shadow in that is shows confirms that stomach is inside the thorax. We did the surgical laparotomy via midline incision where 2 into 10 centimeter defect in the retrosternal space is repaired after reduction of the content with non-absorbable interrupted suture. We also did suture gastropexy in this case. In 2-year post-operative follow-up, the vomiting settled, child is gaining weight, and frequency of LRTI is decreased. So, Morgagni hernia is a retrosternal hernia of the abdominal contents through a diaphragmatic space. Overall, in children, it constitutes 3 to 5% of all diaphragmatic hernias. It can be congenital or acquired after median sternotomy, mainly after for cardiac diseases. It is mostly right-sided, and omentum is the main content. Most cases are asymptomatic and present later in life due to the complications, or they are diagnosed incidentally for evaluation of disease for some other purpose. Acute symptoms in children could be respiratory distress or volvulus. Other symptoms might be mild respiratory tract infection or mild GERD type of symptoms. Morgagni hernia with gastric volvulus in an infant is a rare occurrence. Surgical approach is by transabdominal approach with interrupted non-absorbable suture. It can be done thoracoscopic also, or the laparoscopy is the gold standard. But we didn't do it because of surgical expertise. Then our case 2 is a 11-month-old female with history of recurrent hospital admissions for fever and non-productive cough, which has increased in frequency in the last 1 This is associated with the failure of thrive and treated by pediatrician for recurrent pneumonia. General examination shows respiratory distress, and the right-sided there is abnormal findings are there. Laboratory parameters are normal with the minimal leukocytosis is there. A chest X-ray shows right lower zone opacity and there is reduced right hemithorax volumes and elevated right hemidiaphragm. CT scan axial view shows again liver at the same level with the cardiac shadow with confirmed the elevated right hemidiaphragm is there and consolidation of right lower dome. We did the right posterolateral thoracotomy. The video is not playing.
Dr. Sunita, time is up.
So I just want to show that there the lower basal lobe is here is very dusky in color, and it has no aeration. We did the interrupted repair with non-absorbable suture from medial side to lateral side. Postoperative course was postoperative X-ray shows that the diaphragm pushed down to the one intercostal space down, and 2 years follow up the frequency of RTI is decreased significantly. So eventation is maybe complete or the partial complete eventation involves a part of the diaphragm, mostly it is right sided, and the complete eventation is mostly left sided. Causes can be phrenic injury, nerve injury due to many causes, or the neurological causes due to myelitis, encephalitis, neuralgia, tetanus, diphtheria. It's surgical management indicated especially in infants because there is poor development of thoracic cage, weakness of the intercostal muscle. There is this decreased respiratory mobility of the diaphragm with the paradoxical movement of diaphragm, which causes pulmonary collapse, atelectasis, bronchial and parenchymal infection, and sometimes there is also mediastinal deviation is there. Ideally, it should be diagnosed by the fluoroscopy or real-time ultrasound with MRI. In asymptomatic, there are controversy whether do surgical or conservative approach. Adequate time for surgery is still confusing after phrenic nerve injury because of most of the cases after cardiac surgery especially improves after 1 to 2 years of continuous follow-up. In children, it is considered that as the lung growth occurs up to the 10 years of age, so we must do the plication. There are various options. So eventation is a clinical diagnosis that is challenging, but combined effort of pediatrician, radiologist, and surgeon can identify this difficult situation and can have better outcome. Thank you.
Sunita, any questions, please? Yes, Dr. Anjan.
Yeah, nice presentation, Dr. Sunita. Two queries. First, in the first case, how do you I would say commit that the LRTI was because of the small sized Morgagni hernia which occupied less than 1/3 of the, why not a GERD concomitant GERD?
No, LRTI is because of the gastric volvulus. Because of that, patient is has repeated episodes of vomiting and the aspiration pneumonia associated there.
So that's what I'm saying. Gastric.
So in my case, that MH is leading to these symptoms. Asymptomatic. Right. Usually these cases are diagnosed later on asymptomatic because that is rare. So
and in the second case, was a fluoroscopic or paradoxical movement of the diaphragm confirmed by either fluoroscopy or sonologically? Because then how do you differentiate from a phrenic nerve palsy or otherwise? I mean, both will have same kind of picture.
Yes, yes. But no pathological causes I've identified in our case, and these facilities also not available.
It can be done with ultrasound.
So we did the CT scan and that confirm actually that diaphragm is elevated.
Right. Thank you, Dr. Smita.
Thank you.
Thank you, ma'am. Now I call upon. Thank you, ma'am. Now I call upon Dr. Rohit Kapoor, who will be presenting on